I'm so proud really to stand before you as certainly the president of ACEP, but also as colleagues, as clinical colleagues serving on the front lines of our healthcare safety net. I think now that we find ourselves on the back end of the pandemic, now we can finally reflect a bit on everything that we've endured, everything that our specialty, our communities, our patients, certainly the college even has endured since the pandemic. And it's interesting because this week, 4 years ago, actually, marked the really beginning of COVID-19 pandemic, March 2020, when it hit us like a freight train, and we didn't know what hit us. And so it's interesting that now 4 years later, again, there's an opportunity to take a look back to see where we were, where we are today, and where it is that we hope to go in the future. And so I'm just excited to be on this journey with you. I'm excited for the resilience, no doubt about it, of our college and our specialty, and want to take this moment to just remind you of all of the great work that continues to be done by your college in terms of moving the needle around really key advocacy issues, and some might argue more so now than ever, despite the pandemic. And so more to come therein. I also just want to say that my counterpart, actually, Ms. Sedory, who's Executive Director of ACEP, will be joining me for parts of this talk. And so just wanted to certainly acknowledge Mrs. Sedory. So our goals for this morning are to, first of all, broadly kind of provide an overview of the current landscape of emergency medicine practice and advocacy. But also I want to share an update on all of the great work that's taking place around key current ACEP advocacy initiatives, and specifically we'll speak to boarding and ED crowding. We'll also speak to workplace violence in our emergency departments, the workforce in general. It's also interesting that this is match week, so let's talk about that a bit, and the corporate practice of medicine and consolidation. Now, this is not to say that ACEP is not working tirelessly around other issues, scope of practice, burnout, wellness, and the like. There's so many issues, but we decided to focus on just a handful here so that we can have, this is a brief talk, meaningful conversation and a dialogue around these key topics. I'll also share an update around operational priorities for ACEP as well as the Board of Directors, specifically talking about our communications and membership efforts, as well as some innovative things that we're doing around our meetings in particular, and then ultimately talk about leadership pipeline, which is also incredibly important to your Board of Directors relative to operations this year. No conflicts to disclose. And let's start by talking a bit about what we all left, I'm sure, at home, and that is an ED full of patients, boarding patients and the like. So we know that boarding is not a new thing. In fact, it's been going on since probably the 1980s. But no doubt about it, since the pandemic and during the pandemic, we've seen an increased number exponentially across the country of boarding and crowding in our emergency departments. I like to refer to it as hospital system overload rather than boarding and crowding, because the fact of the matter is that it's not an ED problem. It's certainly a systems issue that shows up in the ED as a symptom. And I think until we begin to rightly frame it around it being a systems issue, we're not going to see the movement around solving it the way we'd like. And so I like to refer to it as hospital system overload that really shows up in the ED. And the thing about boarding is that it's hitting our most vulnerable populations more than ever. So our pediatric populations, our elderly populations, our mental health patients who are grappling with, maintaining their mental health and the like. And so that's what makes it even more concerning. And not only do we know, because data has shown us over and over again, that boarding and crowding certainly impacts in a detrimental way patient care and outcomes, it also impacts us in a detrimental way. It impacts our wellness and our mental health, certainly as clinicians in the emergency department. And so it is something that, no doubt about it, is a crisis and has reached crisis proportions. ACEP's well aware of it, and we've been working really hard to try to come up with some solutions. So in terms of what we've done so far recently around boarding and ED crowding, and it's not a new thing, we've been working on it for years, but there was an ACEP Council resolution in 2022. It was put forward by our colleagues in Illinois, and it called for ACEP to focus on ED crowding as a health equity issue, to frame it as such. The resolution asked for us to come up with really a matrix of standards around crowding and boarding, and to put out some best practices. So we did just that in response to this resolution that passed council. We put together first a task force around boarding, and then they came back to us with some recommendations in terms of how to move forward. One of the key recommendations was to hold a summit of multiple stakeholders to come up with some solutions around boarding. And because we know that boarding and crowding is really a multifactorial issue. I mean, if you ask someone now today, what causes boarding? It's like, well, gosh, where do I begin? It truly is multifactorial. And in order to address a problem that has many factors involved, you really have to have a multi-stakeholder approach to it. And so to that end, ACEP decided to go to the top. We actually sent a letter to the President of the United States. This was around November of 2022. This is after having collected over 150 stories from emergency physicians all over the country about the catastrophic impact and effects of boarding on patient outcomes, and certainly even on clinician well-being. You know, it's interesting because the letter was dated November 7th, 2022. The address on the letter was 1600 Pennsylvania Avenue, Northwest in DC. And it said, Mr. President, that's how it started. I like to look back at that letter because that is how serious we are about making this really not just about the emergency department. So we sent out that letter, and here you see an excerpt from one of the stories actually that we collected from an emergency physician. I just want to read this quote. He said, "I can't remember the last time I got to consistently see and examine patients appropriately in a room or a bed and not from a chair. I've seen people code in the waiting room and admitted people to the ICU from the waiting room. It's unsafe for patients and frankly unsafe for us too." And we know that there are no truer words than that. In addition to sending the letter to the White House asking that they join us in creating a summit around this issue, ACEP has also been supporting a piece of federal legislation called the Improving Mental Health Access from the Emergency Department Act. And this would provide funding for communities to ensure that mental health patients have access to follow-up as an outpatient, which we know would help move them out of the emergency department and into the care that they really need. So despite reaching out to the White House, and we actually had a couple of meetings with some of its staffers, didn't have a meeting with the president, not yet, but in those efforts, you know, they really honestly didn't give us an answer in terms of our ask. So instead, ACEP decided to put on our own summit around boarding and ED crowding. So in August, I believe it was August of 2023, at our Washington, D.C. headquarters, we actually hosted a summit of multiple stakeholders, and you see a picture here of us all sitting around the table. We got together for 7 hours that day and just talked about the issue of boarding and crowding, how to fix it, and how to work together around solutions. And I can tell you, I've been active with ACEP for many, many years, and this meeting felt different. It felt different because the people at that table were more than just emergency physicians. In fact, we were the minority in the room in terms of numbers. We had representation from EMS, patient advocacy groups, the hospital was represented. We actually had 2 different hospital association, National Hospital Association groups. We had IT database companies there as well. Etc. Just the nurses were there as well. And so it truly felt like a multi-stakeholder situation where we weren't just continuing to preach to the choir, because we know it's a problem and we know that to fix it, it's going to take many people to be involved. So at the end of that summit, we actually decided on 3 focus areas in terms of working to ameliorate the impact of boarding. We really boiled it down to 3 key issues that cause its boarding, understanding that there are many others. But the ones that we decided to focus on as a group are staffing shortages, which we know is definitely a big deal, Transfer delays also certainly impacting boarding and also crowding. And then misaligned financial incentives for sure plays a role when it comes to ED crowding. And so a lot of really good things came out of that summit. From the representation from the Hospital Association, for example, we've continued to have dialogue about how to work together to impact boarding and ED crowding. Specifically, just last week, actually, we had a meeting with the CMO of the American Hospital Association where we talked about boarding and crowding and how to get together on this issue to bring an end to it. But also, in addition to that, there was representation at the summit from the Agency for Healthcare Research and Quality, or AHRQ. And from their presence there at the summit, ultimately, and you see here, this is the letter from Xavier Becerra, the Secretary of the Department of Health and Human Services for the United States, who has since asked that AHRQ lead a directors roundtable, a work group, to determine what the solutions are around boarding in the emergency department. We're super excited about this because this means that we're officially partnering with a federal entity with power to come up with some solutions around boarding and ED crowding. And I just highlighted in the circle here a key aspect of this letter. It says that the Secretary has charged the agency to use its unique statutory authority to improve healthcare nationwide and its ability to work with HHS partners to convene a multi-stakeholder directors roundtable. We anticipate that this roundtable can be organized in the next 6 months and that we will identify actionable steps as well as opportunities to chart public and private strategies to address ED boarding and crowding. And so we've since had a couple of meetings around this end as well, and we're looking forward for more to come and efforts to, again, ultimately end boarding and crowding in our emergency departments. Also, just want to let you know that work is being done to create a quality measure around boarding. There's actually not currently a federal quality measure that speaks to ED boarding, and we know that when we are incentivized to make good decisions in terms of our patients and their care, that it tends to go a long way. Currently, Yale, or actually the Center for Outcomes Research and Evaluation at Yale, is partnering with CMS to come up with an equity of emergency care capacity and quality measure. This would be an electronic clinical measure that through CMS, individuals or institutions and emergency departments are responsible for complying with. And I just listed here the 4 key areas of this proposed measure, which has not been finalized yet, certainly it hasn't gone into effect. But essentially it would call for there to be no more than an hour for a patient to be placed in an ED treatment space, that the encounter would have to include a medical screening exam, and that the patient would board for no more than 4 hours and would have no longer than an 8-hour length of stay. So I know those numbers don't sound awesome, right? 8 hours is still too long, and we know that. But the way it works in terms of the science of quality measures is that there has to be a gap, first of all, to be closed. And so this is actually a great step in the right direction. We're really excited about more to come in terms of, again, there being accountability and incentives when it comes to ED boarding and crowding. You should also know that LAC this year in April in DC, our Leadership and Advocacy Conference, boarding and crowding will be another one of our top advocacy issues that we take to the Hill in April. And so certainly if you haven't made plans to attend that meeting yet, please do. So more to come on this really important effort. So let's shift gears and talk a little bit about violence in the emergency department. I'm sure that we all can probably say that just in the past week, there's been some violent act in the emergency department. I can tell you, I work clinically at GW in DC, but I also work at the VA hospital in DC. And no doubt about it, I'm very mindful of where I position myself now in the ED while I'm doing my work. And that's unfortunate. And that's just because I'm aware of the risk, really, for violence in the emergency department. We know that nearly 50% of emergency physicians actually report being physically assaulted at some point while working, and that 85% of emergency physicians believe the rate of violence has certainly increased significantly over the past few years. 2/3 of emergency physicians report having been assaulted at least one time over the course of their career, and 1/3 of those individuals say that it's happened more than once. We know that our nurses and other staff are also particularly vulnerable when it comes to violence in the emergency department. In fact, emergency nurses say that they experience violence at least once every couple of months. And that 100% of ED nurses say that they at some point have experienced some type of assault, whether that's verbal or physical. So indeed, this is no doubt about it, a major problem that is really plaguing our emergency departments across the country. We actually put out in 2022 a survey of about 3,000 emergency physicians to, again, get a sense of what is going on relative to violence in our emergency departments and how is it impacting them as well as patient care. Well, 9 out of 10 emergency physicians reported that violence directly impacted their ability to do their job and take care of patients. 8 in 10 said that the violence seems to be increasing wait times, and 60% say that patients leave without being seen due to violence. I mean, who wants to be around that? And so we know that we're actually having missed opportunities to actually take care of patients in the way that they deserve just because of violence. We also know that there's increased burnout amongst healthcare workers related to ED violence. In fact, 85% of emergency physicians say that it impacts their productivity as well as increase their emotional trauma as well as anxiety. And so we know that no doubt about it, this is linked to the environment that is causing so many issues relative to our workforce and attrition and the like. And so no doubt about it, we have to do something to improve and hopefully just resolve altogether ED violence. Part of the problem is that there are a lack of protections when it comes to these acts taking place in the emergency department. In fact, only 2% of assaults in the ED result in charges being pressed against their attackers. And almost 30% say that the most common response to violence is just to put a flag on the patient's chart. But that there's not much more oftentimes done apart from that. I actually had the pleasure of speaking at the American Trauma Society's annual meeting a year ago, talking about workplace violence. And I can tell you that this is impacting not just the emergency department, but the hospital widely. It's certainly not just affecting emergency physicians as well. And one of the take-home points from that meeting that I spoke at was that many people feel that they are actually deterred from reporting this violence because nothing would be done about it. In fact, I had a handful of clinicians share with me that they had been assaulted, and when they thought to call the police and maybe file charges, they were asked to not do that, in fact. That some people were actually told that, you don't want the perpetrator to know your address or where to find you if you file a report. That information would be perhaps public knowledge. I'm not even sure if that's true, but certainly there is a sense that, there's no need to report it, nothing will happen. And so we kind of accept it as just being a part of the job. And that really has to come to an end. I think the first key piece is that there has to be a culture shift again, that there's zero tolerance for violence in the emergency department. We know that over the years, due to various factors, the airline workers and airport workers have significant protections, right, when it comes to violence against them. And so ACEP is thinking, why can't we have those similar protections? We know that healthcare is different, certainly, because we're dealing with patients in need. We have an obligation to serve. But certainly there can be a carve-out, there can be a way to ensure that we can be safely taken care of in order to do our job. The Joint Commission has been really involved of late in terms of creating some standards and some reporting requirements for hospitals. In fact, they released a summation of such of these recommendations in January of 2022. And so that's really helpful from a hospital standpoint to know that there are regulations. But I'll tell you that honestly it starts at the top. Oftentimes in our emergency departments, it starts with specifically there being awareness around the violence in the emergency department and there being training, certainly for us in terms of preventing the event in the first place, understanding how to de-escalate, but also understanding how to impact penalties should there need to be any relative to violence against healthcare workers. So I just wanted to share a few policies that ACEP has around violence, and I can tell you that referencing ACEP policies can be really helpful in terms of going back to your shop and saying, hey, to your chair, to your fellow directors and fellow leaders that, this is what ACEP thinks about violence or any other topic that there may be. So you see in 2019 of April, we actually approved the Violence Prevention and Intervention for Emergency Medical Services Systems policy. And then in April of 2021, the Board of Directors approved safer working conditions for emergency department staff, followed by revising in June of 2022 the protection from violence and the threat of violence in the emergency department. And essentially, ACEP believes that we should all certainly be able to feel very safe when we go to work. And these policies speak boldly to not just awareness that there is a problem, but that there be action taken to ameliorate and improve these conditions. So what else is ACEP doing about violence in the ED? Well, I'm glad you asked. We actually are taking a two-pronged approach from a policy standpoint. The first piece is really strengthening prevention programs, because obviously if we can prevent it from happening in the first place, that would be ideal, but also establishing penalties that are equitable for assailants when necessary. ACEP supports two pieces of federal legislation that we've been trying to get over the finish line. Both in some form have actually passed the House, and we're hoping to get them passed in the Senate, because it would be really nice to have a piece of federal legislation that supports law and order in the emergency department, that protects us as clinicians in the emergency department. So the first piece is the Workplace Violence Prevention Act for healthcare and social service workers. This is actually calling on OSHA to come up with some guidelines and reporting requirements for hospitals and emergency departments around workplace violence. And the other piece is the Safety from Violence for Healthcare Employees Act, or the SAVE Act. This piece was actually introduced by Larry Bouchon, as well as Madeline Dean of Pennsylvania, Larry Bouchon of Indiana. And it really is, again, a law and order piece of legislation that says that it is a criminal offense at the federal level to assault a healthcare worker, and it creates a penalty around it. What I love about the SAVE Act is that it also has a carve-out around patients who may not have capacity to make good decisions. And we know that that's really important for us, certainly in emergency medicine, where we're dealing with people who are under the influence of a myriad of things. And so that's what I love about the SAVE Act, is that it actually has an equitable piece as well. The goal is not to put people in jail. Really, the goal is to have a deterrent from the activity in the first place. And so you see here how we have partnered with the Emergency Nurses Association around these pieces of legislation, as well as the American Hospital Association. This picture here on the far right is where we were actually on Capitol Hill in DC just a few weeks ago, partnering with the American Hospital Association, promoting the SAVE Act and trying to get it over the finish line. You know, one of the unique things about ED violence is that we can't really record in the ED because of privacy issues and the like people record on airplanes and the like. And so one of the things I said to the staffers when we were in DC at this Capitol Hill briefing was that you all have to be our ears and our eyes to push this message forward to Congress so that we can get this piece of legislation across the finish line. So more to come therein, but we're hoping to have finally a piece of federal legislation that speaks to the importance of protections for emergency department clinicians. And this is actually a workplace checklist that ACEP put together that I would encourage you all to check out if you haven't yet. Essentially, it's just a checklist that has 4 categories. It speaks to there being a prevention plan, transparency, analysis, as well as some type of personnel and law enforcement. And this is actually found on the ACEP website. I have the link at the bottom where you can access it. But it's a nice starting point to just kind of assess where your department and your hospital is in terms of protections relative to violence. And again, this is a tool that you can share with your fellow leadership in order to push forward for better protections in the ED. So let's shift gears again and talk a little bit about workforce. And it really is talking about protecting our greatest resource. That's you, certainly, as clinicians in the ED, as well as preparing for our future. ACEP has put forward 5 pillars of efforts around workforce. One is to define EM residency standards for the future, and we actually submitted to ACGME some recommendations, I guess it's probably been a year ago now, around how to revise the requirements for EM residency training. They actually do revise those requirements every 10 years, and lucky for us, they did that back in, I think it was 22 or so. And we're still looking for those final recommendations that they'll put forward. Number 2 speaks to ensuring that the business interests do not supersede education or patient care. And we're going to speak more to that shortly. We know that there's been a lot of corporatization and consolidation that have impacted in some instances, overridden really the importance of education, quality education, and patient care. Also, our goal, number 3, is to support emergency physicians in all communities, and so certainly not forgetting our rural colleagues in underserved areas to ensure that there are resources there so that they can continue to do their job of providing quality care. Number 4 speaks to scope of practice, which is important to emphasize the unique role of the emergency physician. We've done a ton of work around scope of practice. As a matter of fact, ACEP President-elect Dr. Haddock was just at the AMA meeting, state advocacy meeting, a couple months ago, speaking about scope of practice relative to emergency medicine. And the 5th piece is to broaden demand of emergency services in order to meet evolving needs. And so we know that we have to think outside the box of the brick and mortar of the traditional ED and figure out how to kind of reinvent ourselves in many ways, how to improve the demand for our services as we also focus on the supply side. So first, I just want to share a little bit about the density of emergency physicians in our country. So you see this map. The darker the shade of blue, the higher the density of the emergency physicians. And we know that there are about 15 emergency physicians per 100,000 population. This is actually from a study done in 2020, and so this may be a little bit dated, but not too far off, I'm sure. And about 92% of those emergency physicians work in urban areas, the majority remaining, of course, working in rural areas. So the majority of us are certainly in urban areas. And we see that there is definitely a paucity of us right in the middle of the country, in the Midwest. And so truly when you talk about workforce and numbers, it's really not so much about there being a workforce shortage per se, but really it's a distribution problem in terms of where we are actually practicing. So this is an excerpt from the first page of something you may have heard about. It created quite a bit of a stir. This is the 2021 workforce study, which is really an effort of multiple emergency medicine organizations, including ACEP, where we conducted pre-pandemic. Now remember, this is before the pandemic, this study that looked at workforce supply as well, and that's the supply of physicians, PAs, as well as NPs. It also estimated productivity, it estimated attrition, and then it came up with what we can project as an estimation or as a prediction of workforce in 2023. And the conclusion was that based on all of these factors that this paper looked at, that there would actually be a surplus of about 7,800 emergency physicians by the year 2030. Now, a couple things I want to point out about this study. First of all, it was pre-pandemic. A lot has changed since the pandemic. The attrition rate in this study really estimated to be about 2 to 3% attrition. Some people actually estimate that attrition may be up to 7%. So certainly the formula has changed. The other thing to emphasize is that this paper did not look at rural communities per se or that distribution that I just spoke to as much. And so that's another piece and a factor to consider. So market forces, since the release of this study, have definitely ensued. When we say market forces, what I mean is the factors affecting the supply and the demand of a commodity. So for example, weather can impact things like the supply of commodities, and even social consciousness can impact things like climate change and the like. And so market forces have certainly played a role when it comes to the workforce study and our workforce in general. And again, I think we really have to take a step back and realize that the formula needs to be looked at again because market forces have played a big role. And some say that the unprecedented unfill rate of our MACs for 2022 and 2023 is related to market forces. So this table actually illustrates all PGY1 positions relative to emergency medicine, and relative to emergency medicine PGYs. So we have PGY1s for all across the board, all specialties on the far right side, and then for emergency medicine on the left side. And there are two things that I just want to point out about this table. First of all, let's see if I can get this pointer to work. So first of all, in terms of EM positions, this is where we are here. We know that for 2022 and 2023, we had an unfilled rate that was unprecedented in terms of 219 in 2022 and 555 in 2023. But I also want to point out that the unfilled rate for even all specialties has increased. So even for all specialties for 22 and 23, there was an increase, albeit not as high as our increase, but there was an increase in terms of unfilled rate. The other thing I want to point out is the number of positions offered. So here we see EM positions offered from 2019 down to 2023, and we see how those number of positions offered has significantly increased. In fact, from 2018, we know that there's been about an increase of 50 new emergency medicine residency programs and about 650 new positions. Remember that the number of programs doesn't necessarily directly correlate to the number of positions, because it can be an old program that adds seats, right, to its residency program. And so no doubt about it, the increased number of positions has impacted, again, the unfilled rate within emergency medicine. And to that end, I just want to point out all health systems affiliated with more than three or more emergency medicine residency programs to see where the issue is in terms of this proliferation, really, of emergency medicine residency programs. And so this is a little bit small, but essentially you have the health system listed here and the number of approved positions in terms of EM residency spots. And then the highlighted green box here speaks to the ownership type. So we see at the top is HCA Healthcare having, and this is actually, by the way, a couple years old in terms of data, but about 480 or so positions offered in EM with about 16 different EM programs or so. We know that HCA is private equity backed and for profit, but I also just want to point out that number 2 is Ascension Health, which is a nonprofit, and also had several positions offered as well as primary sites. And if you go even further down, there's academics, there's public, there's private, there's for-profit, not-for-profit. And so for ACEP, the key is to find out where is the problem and address it, because we do think proliferation is a bit much, and it has created a problem, really, in terms of our workforce. But there are even academic programs on there on this list as well. So I just think it's important that we are aware of the players in this space relative to the proliferation of EM programs. And while we know that the increased number of programs certainly impacts our workforce and the match, I love this slide because it lays over the number of applicants to emergency medicine programs with burnout, as well as the number of applicants and the number of positions offered. And so it's really, again, a multifactorial issue. We see that for burnout, as burnout increases, which is in the red, as burnout increases over the years, we see a decrease in applicants, pretty much a direct correlation inversely. And we see that the increased number of EM positions offered correlates with the percentage of unfilled rates. So again, it's a multifactorial issue with so many factors there. And it's just important that we recognize all of them and try to attack them all to improve our workforce and the like. So I have some good news. Again, fittingly, this is match week. And we're really grateful for actually seeing an increase in the number of emergency medicine applicants for this year, 2024. In fact, up to over 4,400 applicants so far in terms of emergency medicine practice, which is significantly up, right, from 2023, where we had about 3,200. And I think it's interesting to even point out that in 2021, so this was a year into the pandemic when we were all really cool heroes, everybody liked us, everybody wanted to be us, we were on the front lines, we had our Pampers on at work, we looked really cool at work, we were really hot actually at work in those Pampers. But even that year, there were 4,300 applicants and we were popular that year, right? And then it took a nosedive in 2022 because the pandemic toiled on, people were getting tired. But this year, we've actually even exceeded the number of applicants as compared to the year 2021. And when we break it down in terms of those applicants, We know that in general, we have seen an increase in MD, DO, as well as IMG applicants, but we've seen a pretty significant sharp rise in the number of IMG applicants or international medical grads for emergency medicine. And we're seeing that for our MDs, it's actually definitely going up, but certainly not as sharply as our applicants from DO backgrounds as well as IMGs. And then I also have another piece of good news. When you look at burnout, EM versus all specialties, we're seeing that between 2023 and 2024, we've actually gone down a little bit in terms of burnout, from 65 here to 63, which is helpful. I mean, I'll take it, any progress in the right direction. And so I'm hopeful that we are indeed getting there. So let's talk a little bit about the corporate practice of medicine and consolidation. We know that certainly there have been so many increased mergers and acquisitions over the past decade or so. Actually, between 2008 and 2014, about 750 different mergers and acquisitions. There was actually a study that CMS put out that showed that between the year 2012 and 2020, the number of emergency physicians employed by a large group, that meaning more than 500 emergency physicians, increased significantly. It was 1 in 7, and by 2020 it was actually 1 in 4. So certainly the landscape is changing around corporatization as well as consolidation. And ACEP has always really fought for making sure that ad practices relative to corporatization and consolidation does not impact emergency physicians or the care that we provide our patients. But we've upped the ante, and we've heard feedback from members that maybe ACEP could be doing more, and so we've done just that. In fact, over the past year, so much work has gone into really impacting the role of corporatization and consolidation in emergency practice. Here you see a policy that your board of directors actually released in June of 2023 that speaks to the corporate practice of medicine and how ACEP feels about it. We've also developed numerous resolutions and policies over the years, again, just purporting that business interests should never supersede emergency physician wellness and certainly our ability to take care of patients. And we don't just have policies about it, but we're actually putting it into action. And so we actually urged the Federal Trade Commission to finalize a ban on non-competes, which was finalized. This was back in March of 2023, so almost a year ago. We also had the Honorable Chair Khan join us for our Scientific Assembly kickoff this past year in Philadelphia to talk more about really corporatization and its role in healthcare and what the federal government thinks about it in terms of ensuring equity and adequate care. And then just recently, that was December of 2023, myself, Ms. Sedory, as well as our lead in the DC office legislatively, Laura Luster, met with Jonathan Cantor, who's the head of the Department of Justice. And we have this picture here outside of the Antitrust Department of the Department of Justice. And that conversation had more to do with consolidation, particularly relative to the insurance industry. We know that a lot has happened in terms of bankruptcies over the past few years of staffing groups and the like, and so ACEP has certainly worked hard to be there for our members during career transitions. We actually filed an amicus brief for the California lawsuit on physician practice. That was probably a year and a half ago now. And we also are offering specific supports to physicians in career transitions relative to the closure, bankruptcies of various groups. And we also even filed for a notice to appear in court on behalf of our members relative to the APP, or the American Physician Partners, bankruptcy case. And so there are resources online. There's a toolkit in terms of career transitions. At LAC this year in April in DC, we will also talk again about career transitions to ensure that our members feel protected and that they have the resources they need during this environment, which at times can feel a bit volatile. We also have ACEP Open Book, which is really a new, really exciting resource that we offer our members, wherein you can go online and look up various employers to determine what their practices are relative to due process, non-competes, and the like. And so this is actually information that we know you deserve to know when you're making your decisions about who to work for. And so we're really excited about ACEP Open Book, which uncovers a lot of details relative to various employers. So that's online as well. All right, so just briefly, you want to talk about what's on the minds of your board of directors. There are 15 of us, and what our focus areas for the year are. First of all, we're focusing on communication, membership, and innovation. In terms of communication, we think that it's really important that we have a clear and focused message for our members and various stakeholders, and so we've worked really hard to develop those messages and to amplify them. We're adjusting to the digital publications age, moving away from paper journals and the like, and also focusing on how we can better utilize ACEP now as a vehicle by which to adequately and effectively communicate. In terms of membership, we are continuing our recruitment efforts and retention. We have new engagement opportunities relative to membership, and we put out a big survey to our chapters to determine how to better engage our chapters. And relative to innovation, our meetings have been really looked at closely in terms of scientific assembly. We actually put together a tiger team that's really revamping the whole approach of scientific assembly. We're really excited about rolling out some of that this year in Las Vegas. And also put together a work group to look at our leadership and advocacy conference in terms of process, but also ensure that we remain cutting edge when it comes to the advocacy work that we do on the Hill. We have Accelerate, which is here this week, certainly. And then the Emergency Medicine Data Institute is another investment that ACEP has made a few years back to ensure that there is a place in a home specific to emergency medicine data that allows us to expand research opportunities, surveillance opportunities, and the like, and also continue to have our database relative to reporting quality. And then there's the ED accreditation program that we are hoping to roll out this year. That will allow emergency departments to determine standards and to really adhere to various standards in terms of what makes a great emergency department. And so things like workplace violence will be included in that, as well as boarding and the like. So with that, I want to turn it over to Ms. Sedory to talk a little bit, and I know we're running out of time, about finances and operations relative to ACEP. And also how our strategic plan, no doubt, aligns with what the board's focus is.
How many folks really understand ACEP, right? That's what we always kind of wrestle with as an organization. So we are your professional organization. That's what we like to think of ourselves as. We are $42 million like big. So that's a very large organization. We have about 150 staff. We do have our 2 headquarters offices. Our main headquarters office is 10 miles up the road, 15 miles up the road. You might have seen it when you were flying in. You get a great view if you come in those northern runways to DFW. And we're really proud of that building up there, that space. But as Dr. Terry said, we also have a DC office, which is very close to Capitol Hill. We use that a lot when we're in town and we're trying to do all the important work we do. We really do stay very focused on all these myriad of things that we are really trying to tackle. So in addition to our federal advocacy efforts, which Dr. Terry described in terms of some of the work that we do there, we have, as you know, do an amazing amount with regulatory research, regulatory advocacy. We have our reimbursement coding conference going on here at this meeting at the same time, which is really helping to educate folks on exactly how you get paid, how that all fits together, and why we really protect and work on your behalf on that front. We've really expanded our state legislative efforts as well. These days, so much more of our legislative work happens at that state level. And we've got to make sure that our state chapters are aligned and out there fighting on the front lines for you for all of that. And that is both in terms of physician autonomy laws that we're seeing pop up everywhere, as well as so many scope of practice laws that are popping up. Internally, we've got a giant meetings team, we've got a giant membership team, we've got a giant clinical affairs team that's driving all that policy, and then an operational team as well. The pandemic has been tough on every organization, but we've weathered that storm really well. And we continue to make sure what we're doing is both investing in the organization and investing in you. We've been spending a lot on tech investment to make sure we are really kind of prepared and staying ahead where we need to be as an organization. We're investing a lot on thinking about what other membership models exist and how we can make it, being part of ACEP, something that is affordable and meaningful to everyone. Conscientiously, we've also really been thinking about what do we do when it comes to the money we get. We have been very fortunate, particularly through the pandemic, to have received so many more federal grants to support our work. And we continue to see that evolve. We continue to move away from, I think, what some people might have thought of ACEP in the past as being kind of connected with a lot of corporate support and outside support for really elaborate parties at our annual meeting, to being about a group that stays very closely connected to our partners to make sure we are delivering programming to you that makes sense, and staying particularly in that grant space to make sure we can advance where we are in research and all that other investment. So we're really proud of kind of where we've sort of landed, where we're going with the organization, and it is because of the strong partnership we have with our board, as Dr. Terry has described, as well as the loyalty that we have from the members and what that means. And we'd be happy to answer any questions you have. I know you want to talk a little bit more about one of the key efforts you're still working on.
Thank you. Thank you so much for that, Sue. I'm going to wrap up soon because we do want there to be an opportunity for a few questions at least. There's always so much to talk about, so it's always a challenge to get it all in. But I did want to briefly mention that another board focus is leadership pipeline. We talked about the match numbers. We talked about how it's going to be really important that we focus on recruitment. But in addition to recruitment, succession planning, when it comes to ensuring that we can continue to have the operations internally of our committees and our sections and the like, really fuel the pipeline in terms of leadership opportunities. We know that the demand for leaders exceeds the supply, and so that's why it's really important that we're deliberate about seeking out leadership and then preparing them for leadership, funneling them into a particular direction, ensuring that they succeed. And I'm going to slide through this a little bit in terms of some of the demographic data in emergency medicine and medicine in general. But I'll just go back to this slide about how we saw a nosedive in terms of applicants. And so leadership pipeline efforts is incredibly important. And I always say leadership in front of pipeline because I think it's important to not just have a pipeline full of talent, but to hone that leadership of that pipeline. And so we're taking our story on the road. We've connected with AAMC quite a bit around efforts with their career fairs and the like. We have to reach our medical students. We have to reach upstream in terms of that pipeline and our residents to ensure that they have the information they need to know that emergency medicine is the greatest specialty out there. We have also within ACEP the Leadership Development Advisory Group. This is an internal group that works with our members specifically who are interested in climbing the ranks relative to leadership in the college and certainly preparing for even running for the board of directors. And then I just wanted to highlight a few legislative wins and efforts that our chapters have participated in, which really speaks to, again, also leadership pipeline at the chapter level. Scope of practice wins are indicated in the blue star. Corporate practice of medicine legislative efforts and wins in Oregon and California, for example, with the brown star. There have been legislative wins relative to violence in the emergency department as well, which you see in the purple stars for Virginia, Michigan, and Oregon, and even Medicaid wins in terms of reimbursement in the states that you see there located in red. So this is, again, an opportunity, an example of leadership pipeline at the chapter level. The American Board of Emergency Medicine actually put out a healthcare administration leadership and management program that allows us to prepare ourselves to lead in terms of hospital administration and the like. And we know that we need more emergency physicians in the driver's seat when it comes to running our hospitals and certainly our ED. And so this is another opportunity that you might consider through ABEM. So just in summary, ACEP is partnered with our federal government to work on bringing an end to ED crowding and boarding. We're working really hard to get federal legislation passed relative to ED violence and workplace violence. In terms of workforce recruitment, the concerns are multifaceted, but the recent trends do look like they're headed in the right direction. And we know that leadership pipeline has to be emphasized relative to our workforce. We're standing stronger than ever with you around corporate practice, unfair practices in terms of corporate practice of medicine and unchecked consolidation, doing more and more to empower the emergency physician. And the ACEP board is very much focused on optimizing internal and external communications, making strong our membership, and certainly creating the innovation that we need to take us successfully into the future. As Ms. Sedory mentioned, our headquarters, which is a beautiful 60,000 square foot building in Irving, Texas, about 20 minutes away, is here. We're very proud of this building. In fact, this is your building as members. So if you're ever in the Dallas area, stop by. And in fact, if you're here this week and want to tour the building, we can certainly set that up for you one afternoon. And with that, I will end and just say that the state of the college and the specialty is strong. We're getting stronger. We're incredibly resilient. And it's all only because of you. Thank you.